Good afternoon. I'm pleased to present this talk on mitral-aortic coupling. I have no disclosures for this talk. So the objectives of the talk is first to explain what mitral-aortic coupling is, the role of 3D and understanding it, and then what the clinical impact is on it. Okay. So to understand what mitral-aortic coupling is, we first have to go back to the anatomy. And one of the things is when you look at an anatomic picture of the aortic and mitral valves, you see that the posterior portion of the aortic valve and the anterior portion of the mitral valve are actually connected by fibrous tissue called the aortic mitral continuity. It's a fibrous tissue. It's very tough. Now, intuitively, based on this, you would assume that normal function of the aortic valve requires that this tissue and the mitral valve function normally, and so both the valves are actually interdependent. However, the problem is with 2D imaging techniques, you can't actually understand what's really going on because all you have is when you have a single slice is that you see the planar motion. You don't actually see that the 3D valves or the annulus of the valves actually move in different planes, and you don't really get an accurate quantification of what these valves are doing. Now, to look at this, people have actually used animal studies where they've implanted crystals, but that's not very practical because you can't follow these animals serially and look at what happens when you intervene or over time with the disease process. 3D echocardiography has allowed us to actually look at the interactions between these valves. In this picture, we have a short axis cut plane through a 3D data set, and you can see the mitral valve over here and the aortic valve, and we can actually see this continuous fibrous continuity right in the middle. This is an on-fast view looking right down at the two valves, and like that anatomic cartoon that we saw, this is actually what it looks like in a live human person. So, just looking at the valves is not enough. We have to be able to quantitate what's going on. There is no single measurement that actually summarizes what aortic mitral coupling is. It's actually being able to look at the interactions between several measurements. Now, how do we do this? Initially, we developed custom software. And this custom software took the 3D data set and was able to track the valves, the mitral and the aortic, in 3D time and space. Things that we were interested in was looking at projected aortic annular area, 3D mitral annular area. We looked at the mitral longitudinal displacement. We could look at the aortic mitral annular angle, and we could look at the mitral annular height. Other things I haven't shown here include the distance between the center of the mitral valve to the center of the aortic valve, and there are multiple other measurements that you can look. Commercial software has now been developed where this process has actually been much easier than the original custom software. It's much easier to use, it's much more automated, and it can actually provide even more measurements than that we originally used for our studies. These are just a few examples of the multitude of measurements that could be obtained from these software. I'm not going to read out the entire list. This is actually from the aortic valve side, and this is actually the number of measurements that can be obtained from the mitral valve side. So going back to our custom software when our first interest in aortic mitral coupling, we actually first looked at normal people just to see, does this actually exist? What do we find? And one of the things, if you look at the top graph, we have area along the y-axis and the time along the x-axis. As you can see, for mitral annular surface area, in systole it's smallest, and then during diastole it increases in size. In contrast, if you look at the bottom graph, you see that in systole, the aortic annular area is actually, early systole, it's actually the largest, and actually decreases in early diastole. And so the aortic and mitral valves are actually interdependent. Mitral annular contraction facilitates the aortic annular expansion, okay? And when you contract the aorta, you actually facilitate mitral annular expansion. The two valves depend on each other for normal function. What does this mean? Well, it means that diseases or surgical interventions affecting one valve may actually have unanticipated effects on the dynamics of the second, quote, normal or unaffected valve or uninvolved valve. Does this exist clinically? Well, there are a lot of case series looking at the surgical literature, looking at it initially at aortic valve replacement and looking at mitral valve, what happens to the mitral valve afterwards. And this is actually a review from from a surgical group in Quebec, where they actually looked at all of their patients who underwent isolated aortic valve replacement. And they actually broke it down by mitral valve etiology and looked at the effect on mitral regurgitation after their surgery. If you look on the y-axis, they have the percentage of patients. The white bars means they have a decrease or an improvement in their mitral regurgitation. And you see those who had technically normal or ischemic or functional mitral regurgitation had a much more improvement than those who actually had something abnormal with the valve, such as rheumatic or myxomatous. These findings still hold true in the TAVR realm. This is out of the Partners trial, and taking all their patients. Once again, the percentage of improvement on the side. And in the first is the people who have moderate mitral regurgitation at baseline, and those in the trial who had severe mitral regurgitation. If you focus in on the blue and the light pink, you'll see that the majority of patients with mild, after TAVR and at 1 year, had an improvement in their mitral regurgitation after fixing just their aortic valve. In fact, overall, 55% of patients who had at least moderate mitral regurgitation improved at 1 year. And when they looked at multivariate analysis, they found that those with functional mitral regurgitation actually were more likely to improve, so those without disease. So how does that happen? Well, first we looked at those with severe aortic stenosis undergoing surgical aortic valve repair and replacement at the University of Chicago. And when we did this, we took only isolated valves, so they didn't have any mitral valve problems, and they all had normal left ventricular problems. So then this is a 3D data set just showing aortic stenosis. This is just an example of a control patient, and as the video loads up, you'll start seeing that there's a lot of motion within these two valves in a normal patient as we track the valves back and forth. This is a patient with aortic stenosis, and you'll see that the aortic valve doesn't actually move or contract or do very much. So what happened to the aortic valve? Well, with aortic stenosis, we didn't actually find that the aortic annulus actually changed very much in size, but after valve replacement, it actually became much smaller. When we looked to see how that impacted on structures below it, we looked at the LVOT. And we found that first, the LVOT had a normal dimension in normals, and then with aortic stenosis, it didn't change. But after valve replacement, it actually shrunk. But we're not here to talk about the LVOT. We want to know what happened with the mitral valve. So in this graph, we have controls on the left, aortic stenosis in the middle, and aortic valve post-replacement on the final column. And we can see that there was no difference between controls and those with aortic stenosis in this population. However, after aortic valve replacement, the intercommissural diameter was actually significantly smaller, and the anteroposterior diameters were starting to get smaller. Mitral annular displacement was also reduced after aortic valve replacement, and this is a marker of LV dysfunction. So what happened? Well, with aortic valve replacement, you have a smaller LVOT. You also have this valve now sitting and sewn into your aortic mitral fibrous continuity, and you have a smaller mitral or less distensible mitral annulus. Together, that impedes your emptying and filling, and so the result is actually lower ventricular volumes and probably improves coaptation and decreased mitral regurgitation. So overall, for isolated aortic valve replacement, your normal mitral valve is actually affected because it reduces both aortic and mitral areas throughout the cardiac cycle. You get a reduction because of the aortic valve ring. And you also reduce mitral annular motion when compared to the aortic stenosis pre-AVR, and it actually may have influenced the subclinical decrease in function we see after aortic valve replacement in some patients. So TAVR is this new thing that everyone else is doing. Do we find the same effects in our TAVR patients? So we next took a group of patients who underwent TAVR. Now this is a mixed bag. Some of these patients had lower EFs, and some of these had a lot of calcification. Overall, what happened to the aortic annulus with TAVR? Well, compared to our controls, actually, in our pre-TAVR patients actually had a lot more calcium than our previous study, and they also had a decrease in the aortic annular area. After this, the aortic annular area remained small. That's not surprising. When you implant TAVR valves, you're not actually debriding of any calcium, you're just crushing it against the wall. But more interestingly, there were changes in the mitral valve. First, in our pre-TAVR patients, the mitral annular dimensions were actually seemingly smaller in the intercommissural length. As well, after TAVR, if you look in the first row, the anterior-posterior dimensions actually decreased also. We suspect that that's because if you implant the valve over here and you have tough calcium over here, then you're just pushing that wall inward. The mitral annular height was decreased before TAVR and remained decreased after TAVR. And mitral annular displacement also was decreased before TAVR and after TAVR, but that is probably related to LV function. Now, could this all be because I've just told you that they all had more aortic annular calcification? What if they all had more mitral annular calcification? Well, we actually looked at that. And we found that patients who had mild or less versus more or severe annular calcium, in our pre-TAVR measurements, there was no difference. So it wasn't because of mitral annular calcium, but the actual calcium in the into the fibrous continuity. After TAVR, though, the mitral annular calcium actually did have an effect and made all of the dimensions smaller. And did the valve type actually make a difference? Now, these numbers were small, but no, it didn't affect our pre or post-TAVR mitral annular measurements. Finally, what happens if you have calcium in this region? If you look at the angle, you find that with TAVR, before TAVR, when you have severe aortic stenosis, the angle actually increases because of all that calcium there. The valve is unable to actually bend back and forth. After TAVR, because you've actually almost reinforced that calcium there, the angle remains wide and you don't have any relief. Finally, mitral annular displacement was reduced pre-TAVR and post-TAVR, and once again, as I said, it was likely secondary to OV dysfunction. So overall, how does TAVR affect your aortic mitral coupling? Well, it results in decreased areas in both the aortic and mitral valves due to the presence of the prosthetic valve now sitting in that area and compressing the calcium along that fibrous continuity. Now, I've just focused on what happens if you affect the aortic valve and the mitral valve, but what about the reverse? What about mitral valve diseases? There's a lot of mitral valve repairs that happen. So our colleagues in Milan actually took the software and looked at mitral valve disease patients, those who had myxoma disease undergoing an annuloplasty ring. And what they find was, once again, we have the same effect. So we're looking at the top row, which is the mitral valve, and compared to controls, not surprisingly, people with myxomatous mitral valves had larger annulus, very distensible annulus, but after repair, their annular areas were actually quite small, and the distensibility, if you look at the other ring, so the motion between the end-systole and diastole, was actually quite small and restricted after mitral valve repair. Well, that's understandable. I just put a ring in, and you can't move. That makes sense. But what about the aortic valve? The aortic valve was, in theory, normal in these patients. Well, the aortic valve is not normal in these pre-mitral valve repair patients. The valve is a little bit larger, and there is normal distensibility. However, after mitral valve repair, the valve is actually smaller, less pulsatile, and there's less displacement. How do I know there's less displacement? Well, one of the things with the software you can do is you can actually look at, now if you look in this picture on the left, the motion of the aortic annulus. So here's a long axis of the left ventricle, so you've got your mitral valve over here and your aortic valve over here. And you can look at the longitudinal motion as well as the axial displacement. And when you look at here, we have an example on the graph. Here's the axial displacement, and here's on the y-axis is the longitudinal displacement. You see that for normal patients, there's this big wide circle that happens. With patients with myxomatous valve disease, they actually lose the axial displacement and they have a lot of longitudinal displacement. And that makes sense because their mitral valve is moving up and down very rapidly because of the bigger size. But once you put in the mitral ring, your aortic annulus no longer has that free range of motion and becomes very, very restricted. So in summary, the aortic and mitral valves are linked anatomically and physiologically. Changes in one valve will have an effect on the second valve. The second valve, importantly, should always be assessed prior to and after any intervention. If I can give one message, that would be it. And then can we go with this? Well, newer valve techniques, newer prosthesis, we need to consider what happens to the other valve and perhaps develop our valves with respect to that. And I'd like to acknowledge Roberto Lang and Federico Veronese for their help in this. Thank you.